Good afternoon. 1 minute and we'll start our lecture. Okay, sorry for being late. We had some problems, technical problems. It's too cold, not only for people and for techniques too. And today we'll talk or we'll continue our questions according to the injuries and traumas in maxillofacial area. And as you remember from previous lecture, previous one was about injuries of soft tissue in maxillofacial area. And this lecture will be according to the bone fractures or hard tissues injuries. And here I show you a slide or classification of all injuries, and you saw this classification in previous lecture, and I want to remind you that all classifications in maxillofacial area origin can be divided into 4 points. First, it's soft tissue injuries to the face and intraoral structures. Second point, it's fractures of any facial bones. Third, it's teeth injuries. And fourth, it's a temporomandibular joint dislocation. And according to the soft tissue injuries, we've talked about it on previous lecture. This lecture will start from teeth injuries, and then we'll talk about fractures to the facial bones and temporomandibular joint dislocation. Dental injuries or injuries to maxillofacial area commonly associated with dental alveolar injuries. Careful inspection of the dentition and gingival mucosa will identify most dental injuries. Account for all of the patient's teeth. A vast teeth may be displaced into the adjacent soft tissue, become aspirated, swallowed, or simply lost at the scene. And sometimes radiographs may be necessary to locate missing teeth. Examination of oral cavity begins with inspection. Doctor have to remove all blood and debris from the oral cavity prior to examination. Then record the location and the size of soft tissue injuries. The presence of an empty socket or empty alveolar part of the bone may indicate complete avulsion of the tooth. Gingival bleeding may occur as a result of laceration from an underlying fracture. Each tooth is then palpated to evaluate for mobility. Abnormal mobility may indicate a subluxation or non-displaced injury or luxation. That is the same as a displaced injury of involved teeth. Perform percussion of each tooth. Sensitivity elicited by percussion suggests concussion injury in which the tooth generally is not mobile or displaced but has sustained an injury. Let's see on this slide, and we can see avulsion of the teeth, frontal teeth, and by this teeth we can understand that it's a milk teeth, and it's usual for child or for children fell down and have such a pathology like avulsion of the teeth. It can be completely avulsed, and that means that we can find the empty socket in the oral cavity. And in that time, if it's full avulsion, in sometimes we can replace the teeth in their place, and we'll wait if it will be successful or healed or not. Fractures of the teeth can be classified as a crown fractures involving the portion of the tooth above the gingival surface or crown part, or root fractures involving the portion inside or below the gingival mucosa. The Ellis classification system commonly is used to describe crown fractures. Ellis first. Fractures involve the enamel only. The tooth appears normal in color but has an obvious irregularity in the enamel surface. Ellis second fractures involve the enamel and dentin. The fractured surface may reveal a yellow center from the exposed dentin surrounded by enamel. Also, the patient may complain of pain or sensitivity of involved tooth. And the Ellis third fracture involved the enamel, dentin, and pulp. Bleeding from the pulp may be observed. Bacterial contamination of the pulp can result in necrosis of the pulp, necessitating endodontic therapy. Root fractures represent till 7% of dental alveolar trauma in a permanent teeth. Suspect injury to the root when bleeding from the gingival sulcus is observed. However, these injuries are best detected with radiographs, and of course, in order to diagnose it, we have to do X-ray or CT or other radiographic examination in order to understand if there are any fractures or problems in the root part. And on this CT, you can see intraoral X-ray with the different types of fractures of the root, and we can see vertical fracture by yellow arrow, and by red arrow I show you horizontal fracture of the root. And on the photo we can see open vertical fracture of the crown part, and we can guess that in most cases when it's a horizontal fracture of the crown part, we can find the fracture of the root too, and we can see the bleeding from the pulp cavity and from the gingival or soft tissue adjacent teeth, and only after X-ray we can think about treatment. And what about treatment of dental injuries? In most cases we have to extract the teeth, but in some cases when it's only crown part fracture, we can save the teeth. Of course, we have to do drilling and filling. If it's an open fracture of the teeth, and that means that pulp cavity is opened to the environment or to the mouth cavity, of course we have to do pulp extraction and then root canal filling, and then restoration of the crown part of the teeth. But if it's a root fracture, in most cases we have to extract roots. And as you can see on this X-ray, it's a fracture in the middle of the root. Of course, we have to extract it. We can't save such type of injured teeth. Temporomandibular joint. What is a temporomandibular joint? In order to understand the anatomy of temporomandibular joint, let's talk about anatomy of the mandible first of all. And mandible, it's a lower portion of the face, and it's the biggest or largest and strongest facial bone. The mandible is made up of the body and two rami. The junction between body and ramus is referred to as an angle. The most anterior portion of the body is symphysis, and here symphysis. It's a frontal part of the mandible which connects right and left sides of the lower jaw. The body serves an attachment for all of the lower teeth. Mental foramen containing the mental nerve and artery is located in the anterior portion of the body. The superior portion of the ramus contains the condylar process and coronoid process, which are separated by the mandibular notch. The condylar process articulates with the glenoid fossa of the temporal bone to form temporomandibular joint. And once more, according to the anatomy of temporomandibular joint, it consists of glenoid fossa of the temporal bone and the process, condylar process of the lower jaw. Dislocation of the temporomandibular joint may be caused by trauma, generally by a blow to the chin while the mouth is open. It also may occur from a non-traumatic mechanism such as a yawing, laughing, laryngoscopy, or prolonged dental work. The temporomandibular joint is a hitch and sliding joint. During normal mouth opening, the condyle rotates and translates forward to the area of the temporal eminence. In dislocation, the condylar head slides further forward and becomes locked anterior to the temporal eminence. Trismus and spasm of masticatory muscle prevent the condyle from sliding back. A temporomandibular joint dislocation may occur in a unilateral or bilateral pattern. Obtaining a history from a patient with a temporomandibular joint dislocation can be difficult because he may be difficulty speaking, or there may be difficulty speaking. However, as a history of a trauma or incident event should be sought. The possibility of dystonic reaction should be considered. And temporomandibular joint dislocation may be a chronic problem in some patients, so it's important to ask about prior occurrence. Temporomandibular joint dislocation usually is evident on physical examination or by visual examination. The patient will present with a difficulty talking and inability to close the anterior teeth. The patient with bilateral temporomandibular joint dislocations will present with a symmetric open anterior bite. In unilateral dislocation, the jaw will be deviated to unaffected side. Palpation of the temporomandibular joint area may reveal the condylar head in abnormal position below the zygomatic arch. If the dislocation resulted from trauma, the remainder of the mandible, intraoral and facial areas should be inspected carefully and palpated to assess for any accompanying fracture. Most commonly, reduction of temporomandibular joint dislocation is performed via the intraoral route. To prevent trauma, the doctor's fingers should be gloved with a thick gauze taped securely on both thumbs. To ensure adequate leverage, the patient should be positioned so that the mandible is below the level on the practitioner's or doctor's elbows. Please, our doctor should place thumbs upon the lower molars on the ridge of the mandible intraorally and posterior to the molar. Fingers should be wrapped externally around the mandibles. Then apply firm, slow and steady pressure in a downward and posterior direction. If bilateral reduction is not possible, reduction may be done on one side at a time. Reduction attempts that require excessive force should be aborted because they may cause iatrogenic fracture on the mandible condyles. The patient may wear a soft neck brace and warm compresses may be placed on the temporomandibular joint for comfort. The patient should be instructed to avoid extreme opening of the mouth, such as that may occur during yawning, laughing, dental procedures. Pain relief may be achieved with the non-steroidal anti-inflammatory drugs, for example, ibuprofen and others. Patients with chronic dislocations may benefit from the use of the button bandage, an elastic bandage that is wrapped around the bottom of the mandible and over the top of the head to prevent excessive jaw yawning. And here on this slide you can see photos of our patient with temporomandibular joint dislocation, and we can see open mouth, inability to move the lower jaw, not only closed and open. Patient couldn't move from side to side. It's very painful, and they are unable to move. And we can see deviation, and as you heard, that means that it's a unilateral temporomandibular joint dislocation, and deviation of the lower jaw will be on the healthy side. And on the lower photo you can see reduction of the temporomandibular joint dislocation, and we have to glove our hands and wrap a thick gauze on the thumbs in order when we'll close the mouth or replace temporomandibular joint in its anatomical right position, our patient can fast or rapidly close the mouth, and thumbs can be inside the mouth, and in order to prevent any trauma we have to wrap a gauze. And on the right side of the slide you can see the scheme of temporomandibular joint dislocation, and on this scheme I show you the anterior type of dislocation, and of course if you think, you understand that it can be posterior dislocation, or that means that the head of coronoid process will go posteriorly of the temporal eminence. But of course it's a very rare situation, because there is no enough space for posterior dislocation, and usually we can find a fracture of the process of the mandible due to this type of dislocation. And once more, let's look on this slide of the cranium and bones of the face. Facial area and its bones have typically been divided up into upper, middle, and lower thirds. Upper portion of the face in that area overlying the frontal bone. The frontal bone forms portions of the roof and lateral wall of the orbit. Its thickened anterior portion forms the supraorbital ridges. The supraorbital foramen is located in this area and serves as a passageway for the supraorbital nerve. The frontal sinus is contained within this bone. The middle third of the face is the most complex and is formed by maxilla and the zygomatic, nasal, lacrimal, palatine, vomer, and inferonasal concha bones. The maxilla is the largest bone in the portion of the face. The inferior portion of the maxilla, alveolar process, serves as attachment for the upper teeth. Maxillary sinus is located within the body in the maxilla. Maxilla is closely involved with the orbit, forming portion of the medial and inferior orbital rims, medial orbital wall, and orbital floor. The infraorbital foramen containing the infraorbital nerve and artery is located in the maxilla. Zygomatic bone forms the zygomatic arch. and gives structure and shape to cheek. It articulates with the frontotemporal, maxilla, and sphenoid bones. Nasal bones give shape to the superior portion of the nose. They articulate with the frontal and maxilla bones. Lacrimal, palatine, vomer, and infero-nasal concha bones are smaller, minor bones that may be involved in a maxillofacial trauma but rarely require specific management or attention when injured. And the lower portion, as I said earlier, it's a mandible, the biggest, not biggest, sorry, it's hardest and strongest facial bone. And once more, about it, anatomical structure we'll talk when we'll discuss about mandible fractures. And let's see. Anatomical structure of the mandible and fractures of the mandible. Mandible fractures can be classified under various aspects such as location, type, completeness, number, and the course of the fracture lines. Characterization by the anatomical size involved is commonly the initial stage in classification process. Mandible is the largest and main bone of the lower part of the face. Inferred weak sides of the mandible, which is liable to the fracture, includes angle of the mandible, especially when third molar is impacted, the socket of the canine tooth due to the long root of canine bone amount is less, and the condylar neck. Mandible fractures in maxillofacial trauma occur more commonly due to the prominence of the mandible and comparative lack of bony and soft tissue support. Mandibular fractures is the second most common fracture of the face after the nose and 10th most common fracture bone in a human body. Diamond and Nedwick classified mandibular fractures into several categories. And this classification is mostly used in a clinical practice. And of course, first classification according to the location. And here you can see the same anatomical parts. Symphysis, body, angle of the mandible, ramus, and three processes: coronoid, condylar, and alveolar process. And of course, in most cases, we can see condylar or coronoid processes, fractures, and it's unusual for mandible fracture only or isolated fracture of alveolar process. According to the direction, horizontally favorable, horizontally unfavorable, and vertically the same, favorable and unfavorable. According to the dislocation, on this photo you can see the next classification. We can say about mandible fracture without dislocation and fractures with dislocation. And on this X-ray and photo you can see fractures with dislocation, and we'll talk about later discussing about clinical features of mandible fractures. And fracture without dislocation, we can see X-ray or panoramic X-ray or bite-beam X-ray, and we can see two lines of the fracture near the let's see, it's near the premolar, and we can see that it's a fracture without dislocation. And on the other X-ray, we can see fracture with dislocation. We can see dislocated parts of the bone, and it's a fracture of the angle. According to the number, we can classify mandible fractures as single, double, and multiple. And it's understandable that single fracture, we can find only one line on the fracture. Double fracture, we can find two lines of the fracture in two different places. And multiple, we can find a lot of lines of fracture, more than two or three. And usually, of course, the cause or etiology of the multiple fracture, it's gunshots or blasts. And the other classification according to the number, but not really according to the number, this classification according to the site, which sites which are involved in the process, unilateral and bilateral. And that's understandable too. If it's a unilateral, we can find line or lines of fracture on one side of the jaw, I mean right or left. Or if it's a bilateral, that means that we can find two lines of fracture on different sides. And here I show you different X-ray or orthopontomographs, as we say in Russian. It's double unilateral. That means that we can find two lines of fracture, but on one side of the jaw, on left or right. And here you can see single bilateral fracture. That means that we can find one line of fracture, but on both sides, on right and left. And to put a true diagnosis or the last diagnosis, we have to locate the line of the fracture. And of course, we have to put like this diagnosis. It's fracture, single bilateral fracture of the mandible on right body and left rounds or ankle, for example. And on lower part of the slide, you can see CT with single bilateral fractures of the mandible with dislocation. And here it's a multiple fractures, and we can see a lot of lines of fracture. It can be after car crash or, as I said, gunshots or other most severe fractures, causes of fracture. And about the diagnosis. Complete history trauma should be obtained after cardiopulmonary and vital neurological function of the patient are stabilized. The mandible should be carefully evaluated by extraoral palpation. Mandibular contours such as the ramus, lateral and inferior borders, and symphysis and parasymphysis area should be checked, and continuity of the mandibular bone should be noted. Movements of fragments can be evaluated by bimanual palpation. Ecchymosis and crepitation should be assessed. And I hope you know what is a crepitation. It's a specific sounds which we can hear and which we can feel under the fingers during the very soft movements of palpation of bone fragments, if it's a fracture with dislocation usually. And then after this we have to check mandibular movements. Deviation and restriction of movements should be evaluated considering condylar trauma. Also, the condylar head should be evaluated by palpation to check if it's in the articular fossa or not. And in order to palpate condylar head or condylar process of the mandible, we have to put our fingers inside the ears and ask the patient if he able, of course, to slightly move his jaw, try to open and close and from side to side. And we can feel movements of the process. And if it's in articular fossa, of course, our patient will able to move and by his mandible. It can be extremely painful, but he will be able to do it. But if it's, for example, condylar fracture, our patient will unable to move. Mucosal ulceration, oral bleeding, ecchymosis, and sublingual hematomas should be checked by intraoral inspection. Rule out fresh oral bleeding in the sublingual space or bilateral symphysis fracture to secure airway, especially for anticoagulant drug users. Examination of the occlusion, including loose, fractured, or missing teeth, should be performed carefully. Screening for the mandibular fractures is the tongue blade test. Most patients with mandibular fractures will not be able to exert much bite force because of the pain. The masseters are considered the strongest muscle in the body, and normal adults can usually easily blend and break the tongue blade, which is clenched between their teeth. Patients with mandible fracture are unable to perform this task without extreme discomfort, and difficulty performing this task should be considered at a high risk for mandible fracture. This test, it's an English language test, or you can find this test in English literature, but in Russian we don't use tongue blade test, and we don't ask the patient try to break these tongue blades because it can be painful and can cause a discomfort not only for patients with the fractures and for healthy teeth too, or maybe teeth with, for example, periodontal diseases or periodontitis. How can we understand before, of course, X-ray examination or CT examination? We have to do it in all cases, but before this we can try to put a diagnosis before in order to understand how to transportate or what procedures we have to prescribe and what we have to do for this patient. The aim of the tongue blade test is a pressure on the mandible, and according to the deviation of the pressure on all of the bone, I mean mandible or lower jaw, and patient will feel extremely pain on those areas where we can find a fracture, if it's a fracture, of course. But in Russian we can give this force by the pushing the thumb on the chin, and of course we can press the chin of the patient by our thumb and compress the mandible, and the force of the pressure will be deviated on the mandible or through the mandible, and the patient will the same feel the fracture, extremely pain in the line of the fracture, and he will show us that only on this part of the mandible I can feel the pain. But if it's only soft tissue injuries or some wounds or closed wounds, for example, this pressing on the mandible wouldn't cause a pain. And on this slide you can see bleeding due to the open fracture of the mandible, due to the rupture of the soft tissue of the oral cavity. The second photo, it's a tongue blade test. Third photo, it's a symptom of the step, and I try to show you that due to the fractures of with dislocation, we can find the symptom of step because occlusional surface of the teeth looks like a step due to the dislocation of the bone, fractured bone fragments. And the fourth photo, it's a palpation of the lower border of the mandible in order to find of the symptom of the step and to put a diagnosis as a fracture with dislocation. In most cases, as I said, clinical examination cannot be sufficient to intensively evaluate the entire fractures line displaced small fragments, root fractures of the teeth, and neighboring anatomical structures. Plain films, OPTG, and computer tomography or CT can provide additional data about the fracture for better evaluation of the patient. The purpose of the fracture treatment is to return the mechanical strength of the fracture site to its healthy state and to achieve an improvement in the masticatory muscle's normal function. Fractures that are non-displaced and exhibit no occlusional changes may be amenable to non-surgical management, but majority of the mandible fractures will require stabilization for satisfactory healing and to restore pre-traumatic maxillomandibular orientation. Various treatment strategies have been described and vary widely depending on the fracture location and surgeon's performance and preference. The patient's demographics, comorbidities, dentition, and fracture characterization will all influence the choice of fixation by the treating surgeon. The first stage of treatment is to return the fracture parts to their normal anatomical position, or this stage we can call or name as a reduction. And the second stage is the fixation of the parts in their normal anatomical position. And of course, at this stage, it's a fixation stage or immobilization. If the history of trauma doesn't exceed 8 to 10 days, the fixation of the fracture can be done manually in some cases. In order to control the pain, local anesthesia can be applied. Fractures of the mandible can be treated either with the open method or closed method of reduction. And let's see on this slide what are the differences between closed reduction and open reduction. We'll start from the closed reduction because it's non-surgical reduction. Anatomical restoration of the fragments without visualization of the fracture line is called closed reduction. In closed reduction, both tooth bone and bone-bone stabilization can be used to immobilize fracture to obtain correct maxillomandibular relation, which is called intramaxillary fixation or maxillomandibular fixation. It's usually the basis of closed methods. Intramaxillary fixation is fixing the mandible and maxilla together when the teeth are occluded so that the patient cannot open his or her mouth for a certain period to allow secondary healing of the bone parts. In the closed methods, arch bars are often used with the ligature wires. The wire is passed through the intradental gap. One end of the wire is passed under the arch bar and the other end is passed over the arch bar. With the fine tip tool, the wire is placed under the cingulum or neck of the tooth and the wire is bent to secure arch bar to the tooth. And on this photo you can see Tiger-Tet spleens which are fixed on the teeth, and between them we can see special ribbons which connects or fix mandible with the maxilla. The most important disadvantage of closed therapy is continuation of intramaxillary fixation not less than 3 weeks, and usually it's from 4 to 6 weeks. This may lead to undernourishment of the patient and weight loss, although the patient must be informed about oral hygiene due to the difficulty in cleaning their teeth under the spleens or intramaxillary fixation. Non-displaced favorable fractures and grossly comminuted fractures with a soft tissue loss can be candidate for closed reduction. Maxillomandibular fixation can be performed with the use of ARIC arch bars or IV loops, hybrid arch bars, intramaxillary fixation screws, circummandibular and piriform wiring, and orthodontic braces with hooks. And what else? Usually we use special splints, and on this photo you can see these typical splints which we have to fixate on the patient's teeth, and they can be made particular for this patient before the reduction or before the operation, and they can be done the same for all patients. They can be different, but here you have to understand that the main aim of closed reduction, it's a fixation of bone fragments, and in some cases reduction, and it's a closed reduction. And once more, the course of this reduction, or the reason of this reduction, it's giving opposite force to the masticatory muscles, which were the main cause of dislocation of the bone fragments. And we can give by these ribbons, which we put on the hooks on the intramaxillary fixation or on the splints, and we can give by these ribbons opposite force in order to do closed reduction or replace broken and displaced bone parts in its anatomical right position. And of course you have a question, how can we control or how can we understand if it's successful reduction or not, because it will be indication for open reduction, I mean when it's unsuccessful. Of course, I'm sure that you know the answer. How can we control this? We have to do X-ray after putting these splints in 1 day or in 2 days in order to understand if it's successful or not. And if we will see that the bone parts moves in their right anatomical position and dislocation is not so big as it were before putting the splints, it's successful, and we can stay it in for 3-4 weeks. And what about open reduction? As I said, closed reduction, it's a conservative method or non-surgical method of reduction. And open reduction, of course, it's a surgical approach to the fracture. We have to do surgical approach to the fracture, and the fracture segments are repositioned to their anatomical positions. Compression plates and the bicortical screws are used in a rigid fixation. While this is a reliable method and allow the patient to quickly return to daily fixation, but you can see that it's a surgical method of fixation, and of course we need to do anesthesia, and it can be local anesthesia or general anesthesia. I said about rigid fixation, and there can be semi-rigid fixation. Semi-rigid fixation is performed using mini plates. These smaller plates are placed on the stressed area in the fracture. It's through that micro movements caused by semi-rigid fixation have a positive effect on the callus formation. Monocortical screws are used so that anatomical structures are preserved. It may be possible to perform even under the local anesthesia and with intraoral approach. And it's necessary, and pay attention here, because in this hour we are you and me are maxillofacial surgeons, and we have to think about the appearance of the patient after our surgery. And if it's possible, of course, we have to use an intraoral approach, not through cutaneous, in order to avoid formation of the scar on the face. Occasionally, occlusion can be obtained using intramaxillary fixation and elasticity. The patient is given a soft diet during semi-rigid fixation. It's not mandatory to remove the plates after healing, and we have to give the patient special paper where we have to write that inside or on the bones this patient has metal plates in order to prevent some accidents. On this slide, you can see different methods of closed and combined fixation or mixed fixation and reduction. Let's talk about upper panoramic X-ray. We can see two lines of the fracture. On one side, a little dislocated, and we can see splints on the teeth of this patient, we can see metal wirings between the teeth or inside the gaps. And of course, it's a successful reduction, and we can state during the healing process will start. On the upper right photo, you can see the same situation. It's a fixation of splints, teeth splints, and intramaxillary fixation not by ribbons but by metal wirings in order to close or fix mandible to the maxilla. And we understand that the maxilla is unmovable jaw, and we can easily fix movable to unmovable. And of course, wait for bone healing, which starts after 3 weeks, and it's the main reason why we have to place this fixation or close reduction not less than 3 weeks. On the lower panoramic X-ray, we can see combined method of reduction. It's a close reduction, and we can see splints, and at the same time we can see mini plates like open reduction of the mandibular fracture, and we can see several lines of the fracture, and we can get that the doctor was afraid of complications or dislocations, or maybe it was unsuccessful closed reduction and they have to do open reduction after closed. And on the last photo, you can see intramaxillary fixation. It's a Tigerstedt's splints or splints named by Tigerstedt, and it's usually or usual splints which we use in our everyday practice for patients with fractures. And here you can see open reduction, CT and X-ray, panoramic X-ray with open reduction techniques, plates and mini plates, and on upper photo you can see clinical picture, and of course it's awful. We can see a lot of blood inside the mouth, and even without palpation and other types of investigation, we can say that it's a fracture with dislocation. But even if we are sure that it's a fracture with dislocation, we have to do X-ray or CT in order to be sure that only on this area we can find the fracture, and to understand what's wrong with the teeth, maybe fractured teeth, and we have to extract them. And in the lower photo you can see displaced central line of the teeth after close reduction of our patients, but it's not so visible and anesthetic, and we can stay it. It won't depend on the tuning. On these photos, you can see external fixation, external type of fixation, and of course we can understand, and we can understand it by the photos and scheme. I show you that extraoral type of fixation we can use if it's a comminuted fractures. What does it mean, comminuted? We can find small pieces of bones or fractured bones, and we have to understand and to think what can we do with these small pieces of the bone. In some cases we can save them, but in order to save them we can't use open type of fixation because we have to screw many plates inside the bone, and these parts of the bones are small enough and we can damage or traumatize them, and we can it will be suffer for blood supply. And of course, we are afraid when it's comminuted fracture, we are afraid of necrotizing process of the bones. And you know that this necrotizing process we can call as a post-traumatic osteomyelitis. And in order to prevent this osteomyelitis, we can use external type of fixation. Close reduction will be insufficient. Open reduction we can't use in order to the blood supply, and in order to prevent complications. The last type of fixation, it's external fixation. Of course, this type of fixation has their disadvantages, and these disadvantages, first of all, it's aesthetic disadvantages, because you can see that it's through cutaneous, sharp metal objects we have to fix by them comminuted fracture. And of course we can understand that after this method of fixation our patient will have a scar formation on these places, and sometimes we even can see necrotizing process of the soft tissues. But of course it's much more better than to have osteomyelitis as a complication and to save a part of the jaw. If you have questions, you can ask them and I'll try to read the chart. If everything is understandable, let's talk about anatomy of the nose. The nose is made up of bony and cartilaginous framework. The bony nasal pyramid consists of paired nasal bones and the frontal process of the maxilla bilaterally. Cartilaginous structures include the upper and lower lateral cartilages and the septum. Both of these frameworks are susceptible to fracture. Nasal fractures can be classified on several types, and let's see on this slide. Type 1. Injury restricted to the soft tissue, or only soft tissue injuries and wounds without involvement in this injury bone parts or cartilaginous part. Second type, it's a non-displaced fractures, but second A, it's a simple unilateral, and second B, it's a simple bilateral fracture. Type 3, displaced fracture, simple but displaced fracture. And fourth and fifth types, it's a closed and open comminuted fractures. What about the meaning of the closed fracture and open fracture? I hope you remember. Closed fracture, it's without connection between soft tissue or inner soft tissues with environment, and open fracture, that means that there is open acute wound above the line of the fracture, or even we can see maybe bone parts by visual examination. Deformity of the nose usually will be evident when a nasal fracture has occurred. However, epistaxis without obvious nasal deformity may be only clinical finding in some nasal fractures. What is epistaxis? It's a nasal bleeding. The relative ease by which epistaxis can occur with the minor trauma is explained by the dense and redundant vascular network that supplies the nose. This plexus, known as the Kehel-Bach's area, is representative for the vast majority of the normal epistaxis. However, bleeding as a result of nasal fracture usually originates from other locations within the nose. Edema and ecchymosis of the nose and periorbital structures ordinarily will be present, particularly if examination is performed more than several hours after the injury. Palpation of the nasal structures should be done to elicit and crepitus, deformity of the nasal bones, indentation or irregularity of the nasal bone. In case of dislocation, orbital rim step of present. Uncommon findings such as cerebrospinal fluid or CSF leak posing as clear rhinorrhea, subcutaneous emphysema, mental status changes, neumal occlusion, or limited extraoral or extraocular movement should be prompt, immediate, subspecially referral. This may indicate associated basal skull fracture or mid-face leaf-4 fracture. According to the most principles and differentiation diagnosis of simple nasal fractures and most severe base of the cranium fracture, we'll talk about it in the practice or in the classes. And now you have to see on these photos typical nasal fractures and typical symptoms for nasal fractures. Once more, deformity if it's a nasal fracture with dislocation and swelling, ecchymosis, epistaxis, asymmetry of the face or the shape of the nose, and eye movements due to the force which cause a fracture. Blowout fracture may cause extraocular muscle entrapment. Imaging for isolated nasal fractures rarely needed. CT scans are performed for suspected head injuries, basal skull fracture, or complex facial injuries. And of course, we can do simple X-ray and after it put a diagnosis. Management or treatment of nasal fractures. Principles the same, quite the same as we or as I said you on previous bone fracture or mandible fracture. It's a reduction and fixation. About reduction, we can choose closed reduction and open reduction. Of course, all these types of reduction have their own indications and contraindication indications. And what about closed reduction? It's usually reserved for simple non-comminuted fractures of the nose. The fundamental principle is to apply a force opposite to a vector of trauma to achieve a fracture reduction. And it's a principle of all reduction, of all closed reduction. How can we do it? Now we have to use special instruments. It may be like a forceps, like even scissors with thin blades. We have to wrap them by a thick piece of the gauze and then put in the or push in the infra or inferior nasal concha and then pull it to the nasal bones or under the nasal bones they should be placed. And by the force we have to tract or replace nasal bones in their anatomical right position. And in Russian we use a term like an over reduction, or that means that we have to do reduction more than needed for this patient. Why? Because we can't understand individual experience, or we didn't see this patient before he had a trauma with the normal anatomical of his nose. And of course, due to the fracture, due to the other type of the trauma, it will be edema, and we can see and we can't understand what anatomical position is right for this patient, and we have to do over reduction. And then in a few days, when edema will reduce, we can change the appearance of the nose and do close reduction other type, or in the inner place of the nasal bones by fingers, in order to help our patient to have their normal appearance of the face. According to the open reduction, fractures that cannot be reduced by closed techniques are candidates for formal open reduction via an open septal rhinoplasty. Sometimes the injuries between bones and cartilages may be complex, and fixing one without the other will leave the patient with the ongoing nasal breathing issues. The greater exposure and the direct visualization is a major benefit over the closed reduction. One may need to wait from 6 months after the injury or initial injury to allow tissue to settle before formal open septal rhinoplasty can be considered. And on this slide, you can see open reduction. It can be done immediately after the fracture, for example, and if it's possible, of course, or if our patient, for example, has unsuccessful outcomes or difficulties with breathing, we can delay from 4 to 6 months open septal rhinoplasty. And what about complications of nasal bone fractures? First of all, of course, it's a septal hematoma, and it's usual. We can find it in most fractures, even without dislocations. And of course, inflamed septal hematoma, in case of inflammation or infection, we'll find septal abscess. And here, let's have a few words about these differences between hematoma, septal hematoma, and septal abscess. You understood infected or inflamed hematoma, it's an abscess. But how to understand, have we do something or can we do incision and drainage of hematoma, we can stay it. Of course, this patient should be observed in a few days in order to understand if there are any inflammation of this hematoma or not. If we'll see some pain, or patient will claim on the pain, maybe some hyperemia or edema, of course, that means that it's a sign of inflammation, and we have to do drainage of this hematoma. If everything is okay, and in a few days we'll see that hematoma is reduced, even a little bit, but reduced, and any or we'll find absence of any pain or other signs of inflammation, we can stay it without any surgery. It will be dissolved by itself. Avascular necrosis of nasal septal cartilage leading to the saddle deformity. Of course, it can be, and usually it's a complication of chronic trauma and chronic fractures of the nose. And of course, who may have chronic trauma of the nose? It's in the sports. Nasal obstruction. The reason of nasal obstruction can be due to the dislocation of the cartilages or septum or edema, of the septum or nasal mucosa, and if it's a nasal obstruction after 3 weeks from the initial trauma, it's a way of thinking. We have to do something for nasal breathing, and of course nasal drops isn't required more than 10 days after injury. Blowout fractures, extraocular muscle entrapment, and diplopia. Nasolacrimal duct injury due to the close relationship of the duct to the nasal bones. It's very rare complication, but it can be. And of course, we as maxillofacial surgeons can't do anything, but we have to send this patient on a consultation of the ophthalmologist, and they can inject nasal lacrimal duct in order to open this orifice of this duct. Fracture of cribriform plate and cerebrospinal fluid rare. It can be, and the symptoms of nasal bones and for example, base of the cranium or more severe fractures can be the same, can looks like the same, but there are a few differences. About it we'll talk later, not on the lecture, in the classes. Inability to reduce fractures that cannot be reduced by closed techniques are candidates for open reduction. And that's all about nasal fractures, and the same, if you have any questions, you may ask. Let's have a break, 5 minutes, and then we'll continue. Following fractures of the nasal bone, zygomatic fractures, are the second most common fractures of the face and predominantly occurs in males. Zygomatic bone, in particular, the malar eminence, plays an important part of the appearance of the face. It's a component of the lateral wall and flow of the orbit, as well as the zygomatic arch. Moreover, it contains tiny holes, also known as the foramina, which allow for the passage of important neurovascular structures. Fractures of the zygomatic bone can extend through the suture lines, namely the zygomatica frontal, zygomatica temporal, zygomatica maxillary. Furthermore, the lines of the fracture can also extend through the articulation that the zygomatic bone has with the sphenoid bone's greater wing. And also, the zygomatic arch fracture can occur as a result of or as a comminuted fractures. Classification of I forgot what I wanted to say. Zygomatic bone, you can see by pink color on this slide, and temporal bone, it's a red color, yes, and you can see, you can read the names of the bone. And zygomatic bone and temporal bone connection, it's a zygomatic arch, or it consists or are made by temporal process of zygomatic bone and the zygomatic process of temporal bone. And according to the zygomatic bone fractures or zygoma fractures, zygomatic or zygoma has two major components, as I said and showed you. It's a body and zygomatic arch. Zygomatic body fracture are named the tripod fractures. And classification. Of course, main for us classification will be without dislocation and with dislocation. But before this classification, let's see on classification on slide. Blunt trauma is the most common cause of the zygomatic bone fractures, and Manson's classification of zygomatic fractures are three types: low energy, middle energy, and high energy. Low energy fractures are those that don't result in a displacement of the bone. This means that there may be a crack in a bone, but its alignment is not disturbed. Middle energy fracture are those that can moderate displacement and in some cases comminution. And high energy fractures, for example from MVA, are those with severe displacement and comminution. This is the splintering of the bone into the multiple fragments. Other classification systems are based on the site of the fracture as well as its degree of comminution and displacement, whether inferior, middle, or posterior. Patient with the zygomatic fracture can present with a wide range of signs and symptoms depending on the kinetic force that cause the resultant damage. This will certainly be pain and limitation with regards to movements that are associated with the zygomatic bone. If there is associated injury to the orbit and ocular structures, then there might be localized hemorrhaging as well as a double vision. Patients may develop trismus. What is a trismus? It's an inability to fully open the mouth according to the constriction of the masticatory muscle, and usually it's masseter, and they have difficulty with the chewing. They may also be bleeding through the nose, which depends on the severity of the injury. Cheekbones of these patients may be flattened due to the malar eminence being depressed. There is a palpable step defect along the infraorbital rim, lateral orbital region, or zygomatic maxillary buttress. Furthermore, there is what may be referred to as a flame sign that arises as a result of the tendon of the lateral canal being depressed and disrupted. Patients may also report paresthesia in the areas that are supplied by the nerves that are affected by the injury. And as you remember from the anatomy, under infraorbital rim, we can find infraorbital foramen with infraorbital nerve and the same named artery. And of course, due to the damage or pressure on this nerve due to the inflammation or here pay attention, inflammation, I don't mean infection. Inflammation due to trauma as a response of organism on the trauma or as a result of traumatized tissue or as a pressure on this nerve. This may cause, and it's usual symptom for patients with a fracture of the zygomatic bone with dislocation, some paresthesias or numbness of this area. Here on this CT scan, you can see different types of zygomatic bone or tripod fractures, and I show you by the red arrows the lines of fracture and dislocations of the bone. And I think on the left side of the slide everything is understandable. We can see bone fragments which are dislocated, but on the right CT we can see a step defect on the infraorbital rim, and I show you it, and of course you can understand that it will be visible or by visual examination we will see deformity of the infraorbital rim, and by the palpation we can palpate this step defect. And by the arrow I show you, by the one arrow, I show you fracture of the zygomatic bone, and the other arrow shows you line or area of the blood inside the sinus. Maybe it's a hemasinus, of which when we can find the blood due to a trauma inside the maxillary sinus. But in some cases it can be inflammation inside the sinus which were previously or before the fracture occurs. And here this CT is better than previous. We can see air fluid level in the sinus, and we can be sure that it's a blood inside the sinus. And we can see anterior maxillary sinus fracture and zygomatic comminuted zygoma fracture. We diagnosed zygomatic bone fracture, and we have to know what to do and how to help to our patient, what types of management we can use. And of course they will be the same, or principles will be the same. It's a reduction or reposition of displaced bone fragments and fixation. And first of all, we have to think about close reduction and different close reduction techniques, and most widespread it's a bone hook. In Russian we say that it's a bone hook by Leclusa. It's a name of the author of this bone hook, and it looks like elevator, but in the end of this hook we can see, or in the end of this instrument we can see a sharp hook. Reduction of zygomatic complex fracture using as a percutaneous technique and a hook. And how can we use it? After local anesthesia, we can put this hook on the skin and pull it or press it or push it under the skin subcutaneous fat muscles, and we'll get to the inner side of the zygoma or zygomatic arch. And then we have to tract or by force pull out zygomatic bone in its anatomical right position. The same method of the closed reduction, it's a screw and traction, and we can use percutaneous screw inserted into the zygomatic bone. This allows fracture reduction using the screw and under holding the instrument, and of course it's not so easy to do, and a lot of complications and disadvantages of this method, because we can traumatize easily soft tissues by this screw and by the instrument which holds the screw and tracts it outside. Threaded reduction tool. Threaded reduction tool or Caro-Girard screw is inserted percutaneously into the zygoma and used for reduction. All these methods can be done under local anesthesia, and all these methods, it's a closed reduction techniques. Of course, most simple, it's a bone hook, but in sometimes we can use the screws and the Caro-Girard screws in order to tract or transverse zygoma. What about closed methods of fixation? Oh, by the way, how do you think, how can we understand if it's successful reduction or unsuccessful reduction? We have to understand it in the operatory room or in the surgery room, and we can do it without any X-ray or CT, control X-ray or CT, I mean. Of course, previously of treatment X-ray we have to do. But control, we can stay without control X-ray. And how can we understand if it's successful closed reduction or not unsuccessful? First of all, of course, it's a symptom of the step. We can palpate symptom of the step by intraorbital rim and understand if it reduce or disappear, it's a successful reduction. If we can palpate it the same or it appears after our reduction, it's unsuccessful, and open reduction is required. And the second clinical feature of successful closed reduction of the zygomatic bone fracture with dislocation, it's movements of the jaw. As you remember, I said that one of the symptoms of zygomatic bone fracture with dislocation, it's unable to move and open and close and from side to side move. Let it be move the jaw. Patient can't move and the jaw in fixed position because of the dislocation of the zygomatic bone, and this dislocated bone blocks movement of the coronoid and condylar processes of the mandible. And of course, if it's successful reduction, patient will be able to move the jaw. And we can ask after the procedure our patient to move the jaw, and he'll not easily and not immediately, but in a few minutes by gentle, slow movement, he will move his jaw. If closed reduction is successful, everything is okay, and we can let our patient to stay in a hospital. But if it's unsuccessful, we have to think about surgical treatment or open reduction techniques. And here I show you different clinical pictures of our patients with fractures with dislocation of zygomatic complex. That means of zygomatic bone and zygomatic arch, and in some cases of all sutures or buttresses of the zygomatic bone or connections between zygomatic bone and other bones of the face. And of course, first of all, first open reduction techniques, it's a mini plates. We can use them in order to help a patient without any difficulties. And the other, and here you can see the same stages of open reduction of the zygomatica from different junctions and buttresses, zygomatica maxillary and zygomatica frontal junction. And I'll try to find that X-ray. Let it be here. We can see zygomatic fracture of the zygomatic arch before and after surgical treatment, and it was a treatment without surgery or by closed reduction, and we used hook in order to do reposition or reduction of the zygomatic bone. And we can see that after surgical treatment or after reduction, we can see the lines of the fracture of the zygomatic bone. How do you think? Does that mean that it's unsuccessful treatment? Of course, no, because it takes a lot of time in order to disappear lines of the fracture of bones, not only of the zygomatical bone, mandible, nasal bones, and all other bones. Now, after 6 months, we won't see lines of the fracture, but in some cases even more if it's a comminuted fracture, difficult fracture, multiple fractures, or fractures with severe dislocation, or for example pathological fractures. Of course, it can take more time in order to disappear these lines of fracture, and it's a normal condition after treatment. And the last bone of the face, it's a maxilla. Maxillar fractures most frequently result from high-speed deceleration crashes in which the midface of maxilla strike a stationary object such as a dashboard or pavement. These injuries may also be produced by striking the face with the rigid objects, tire, iron, baseball bat, and others. The Lefort classification system attempts to distinguish according to the plane of the injury. 3 points in this classification: Lefort 1, Lefort 2, and Lefort 3. And what are the differences between them? Lefort 1 level, or lower type of the maxillar fractures, are essentially separation of the hard palate from the upper maxilla due to transverse fracture running through the maxilla and pterygoid plates at a level just above the floor of the nose. The fracture lines of Lefort 1 may be linear or simple or comminuted or complex. And on this photo you can see Lefort 1 fracture, and we can see the separation of alveolar process with teeth and palatinal process of the maxilla from upper face. And on the scheme of the Lefort 1 fracture on the upper side of the slide, you can see palpation and movement of the maxilla in order to understand if there is any fracture or not. And on this slide you can see Lefort 1 type, and it was too difficult to find these X-rays, or these CTs in order to show you Lefort 1, because it's not typical fracture for alive people. What do I mean? Lefort 1 fracture were based on fractures on cadavers, and of course they were symmetrical because it's a dead body and dead bones. But when it's a live body or a live person, it's too hard, or we don't see such a symmetrical fractures of the maxilla as due to the Lefort classification. But this classification of fractures of mandible, it's a widespread and worldwide classification for maxilla, and of course we use in Russia it too. Lefort second, it's a pyramidal type of classification, is also known as a pyramidal maxillary fracture. These fractures transect the nasal bones, medial and anterior orbital walls, orbital floor, then it goes to the inferior orbital rims, and finally transorally fracture posterior maxilla and pterygoid plates. And what have you to remember? Second and third type of Lefort classification begins from the nasal bones, and nasal bones will be broken as a maxilla. And all nasal bone fractures symptoms will find as a for Lefort second and third type. And here you can see Lefort type unilateral, and I wrote that it's unilateral, and previously I said that it's difficult to find bilateral and symmetrical Lefort fractures. And here you can see unilateral fracture and the same air fluid level in the injury sinus, and it's a blood. Lefort 3 is also known as a craniofacial disjunction because the entire mass of the facial bone is separated from the cranial base. This is the highest level of Lefort fracture and essentially separates the maxilla from the skull base. The fracture is a transverse separation of the nasal frontal suture, medial orbital wall, lateral orbital wall, or zygomatic frontal suture, zygomatic arch, and ends in the pterygoid plates of sphenoid bones. It's recognized that many fractures depart from the defined classic fracture descriptions. As with the initial evaluation, the greatest priority is the primary severe, which consists of the ABCs, airway, breathing, and circulation. Once these are secured, a detailed history of event should be ascertained from the patient or maybe witness or first responders. First, the surgeon should inspect the patient's face and assess symmetry. This may require different vantage points, and it's often hindered by bleeding or significant ecchymosis. To obtain the best physical examination of the face, it's important that any cade on blood or debris be washed off to expose the full extent of the injury. Continuous and ecchymosis may suggest underlying bony involvement. On physical exam, the Lefort fractures are often appreciated as a facial distortion and elongation, maxillary mobility, midface inability, and malocclusion. A bony examination should follow. When examining the maxilla, bilateral palpation is often helpful to help assess for step-offs. Both external and internal palpation of the maxilla is necessary. Assessing the stability of the upper jaw may be achieved by firmly pressing one hand against the patient's forehead and manipulating the maxilla with the other. If only the maxilla moves, it's likely to be a Lefort 1 fracture. If the nasal complex moves along the maxilla, Lefort 2 fracture is likely. And don't forget about symptom of crepitation. Ecchymosis, facial edema, subcutaneous hematomas, and epistaxis are often seen in maxillary fractures. The oral cavity should be assessed for mucosal laceration, ecchymosis, and the presence of the bone fragments. An injury of the mucosa may suggest either alveolar or palatal fractures. Examination of the patient's occlusion is vital and should be done in a neutral position. Ask the patient to open and close it and then clench the jaw and see if there is any sensation of the bite being off. Even the smallest change in occlusion can be readily appreciated by the patient and is more sensitive than examination assessment. If any abnormalities are encountered or the exam that may suggest an underlying fracture, craniofacial computed tomography scans should be ordered. Address emergencies related to maxillofacial trauma prior to the definitive treatment. These include airway compromise and excessive bleeding. Severe bleeding may occur from soft tissue laceration or intranasal structures. Combination of pressure, baking, cauterization and suturing may be useful in such situation, and if you were on previous lecture, we've talked about ways of stopping bleeding. The definitive management of all the fourth fracture concerns centers around the restoration of the functional, occlusional, and the reconstruction of stable boniofacial contour. At the present time, the most common way of internally fixating fractures of the midface is with the small plates and screws. It should be made clear that not all the fourth fractures require internal fixation. Particularly minimally communicated for one fracture in patients with a full complement of dentition. If intramaxillary fixation alone is used to manage the four fractures, is generally left in a place for 6 weeks. Intramaxillary fixation is typically performed with arch bars and stainless steel 25 or 26 gauge interdental wires. For edentulous patients, surgical splints or dentures secured to the underlying bones with a screw or with circummandibular and circumzygomatic wiring may serve as a basis of stabilization. Both mini plates and external fixation have been applied successfully to treatment of midface fractures. And here you can see this wiring I've talked about, and plating or mini plates. We can see the wiring of the mandible, of the maxilla, circumzygomatic or through the zygomatic arch. And then we have to screw special screws inside the maxilla and fix this wiring on these screws. And on this slide, we can see extraoral types of fixation, and the same for mandible. We can use extraoral fixation in comminuted fractures, or if we are unable to use mini plates or open methods of fixation. And in some cases, in extraoral fixation and reduction methods due to the maxilla fracture have more advantages than disadvantages. And that's all for today. We have a lot of information, and I hope it was interesting to know how can we, or what methods of fixation and reduction we have in order to help the patients with different simple and not simple, severe or comminuted or multiple fractures of the face bones. And I wish you a happy new year to celebrate these holidays, and we'll see you in January. I don't remember particularly the day, but we have 3 lectures. Once more, Happy New Year. Have a good weekends and holidays, and goodbye.